Hey guys, Dr. Carmen Bryant here, back with another video for you guys. NursingSchool911.net is the website where you can find these videos. And so let's just dive right into it and start talking about SIADH and diabetes insipidus. So obviously these are endocrine disorders. They are polar opposites of each other, right? Like most endocrine disorders. So if you learn one, basically you have learned the other one, all right? So let's dive in and let's first discuss SIADH, or Syndrome of Inappropriate Antidiuretic Hormone. So in this disorder, there is too much ADH being produced by the posterior pituitary. So I used to remember in nursing school with SIADH, I called him Soggy Sid because there was so much fluid being retained in SIADH. So we have too much ADH being produced. Let's talk about the underlying etiologies. So the number one etiology for SIADH is something called oat cell carcinoma. And this is a very specialized kind of lung tumor. Next, we have viral pneumonia. And finally, we have what I call head problems. So head problems encompasses neurosurgery, traumatic brain injury, meningitis, anything that can increase ICP can actually affect the posterior pituitary and its ability to produce ADH. So number one though is oat cell carcinoma. All right, so you've got two lung issues here that lead to SIADH, right? So those are your underlying etiologies. The underlying patho is very simple. There is too much ADH being produced and released, all right? So this tells the kidneys to hang on to fluid, all right, leading to a fluid volume excess. So that is the underlying patho in a nutshell. We're hanging on to too much fluid, making us soggy Sid. So what are going to be our priority assessments? Well, think about your priority assessments for any patient that's in a fluid volume excess. Right? We're going to be assessing daily weights. We're going to be assessing I's and O's very carefully. We're going to be assessing blood pressure because these patients have a tendency to be very hypertensive because of the volume overload. We're going to be assessing pulse quality. Those pulses will be bounding because of the fluid volume overload. Okay, and I'm not talking about rate, I'm talking about quality. When you go to feel the pulse and it is bounding, okay, it's like boom, boom, you can really feel it. We're going to be assessing lung sounds, all right? Lung sounds is going to be a high priority assessment with these patients because pulmonary edema is our scariest potential complication for someone with SIADH. So you're going to be listening to those lungs for things like crackles. You're going to be assessing the patient for reports of dyspnea. You're going to be watching that O2 saturation. You're going to be looking at ABGs, respiratory rate and effort to give you, kind of a warning like, oh, this patient in fluid volume overload may now be developing pulmonary edema, which is a very, very scary manifestation of SIADH because of that fluid volume overload. Also, we're going to look at electrolyte levels, namely sodium. With SIADH, as in with any issue where there's a fluid volume overload, we have the potential for what's called a dilutional hyponatremia. And with hyponatremia, we worry about nervous system issues. And when sodium levels reach 110 milliequivalents or less, there is a potential for developing seizures. All right, so that is another very scary potential complication of SIADH. So the patient's going to be placed on seizure precautions and monitored very closely. Other assessments will look at serum osmolality versus urine osmolality. Well, serum osmolality is going to be very low because we're holding on to so much fluid that dilutes the serum out. Okay, so serum osmolality will be very low. On the flip side, urine osmolality is going to be very high because we're not putting out very much urine, and what urine we are putting out is very concentrated. So urine osmolality will be very high, serum osmolality will be very low. So what is done for SIADH? We are going to place the patient on fluid restrictions. We're going to administer diuretics, typically something like furosemide. We're going to, again, monitor, place the patient on seizure precautions. And we're going to monitor them for signs and symptoms of pulmonary edema. And so that's basically the main interventions. You know, I talked about daily weights and I's and O's. Those can be considered interventions as well. But medical treatment wise, diuretics and fluid restrictions, okay? So on the flip side, with diabetes insipidus, you see that I only have one etiology listed, and that is head problems. Y'all, anybody, if you're studying neuro, if you're studying endocrine, anyone with neurological deficit, with a stroke, traumatic brain injury, neurosurgery, anything that increases ICP, they have got to be monitored for the development of diabetes insipidus. That is our number one underlying etiology for diabetes insipidus, is neurological problems, okay? Always remember that. So what's happening here is that there's not enough ADH being produced and released by the posterior pituitary, leading to a fluid volume deficit. And these patients can urinate up to 20 liters per day. Okay, 20 liters per day. So they are urinating and urinating and urinating and losing volume and losing volume and losing volume. So what assessments are we going to perform as the nurse? Well, it's going to be essentially the same assessments for the most part, but we're going to expect a different outcome, right? So obviously daily weights, we're looking for weight loss here. We're going to be measuring I's and O's. I's and O's are extremely important with diabetes insipidus. But obviously here, the output is going to be much higher than the intake. All right, that pulse quality that was bounding over here, the pulses will be very weak and possibly thready. We're going to assess blood pressure, but we're concerned more with hypotension and tachycardia, because tachycardia is a compensatory mechanism for that hypotension. All right, so we're going to perform those assessments, but we're looking for and expecting different outcomes, right? So what about sodium with these patients? Well, the serum is going to be very concentrated. Sodium will be elevated within the serum, okay, because of hemoconcentration. So a very elevated serum sodium, a very elevated serum osmolality, but a very low urine osmolality, because the patient is putting out so much dilute urine. Urine osmolality will be very low. Now, how does that translate with diagnostic studies? You will more than likely be tested over something called a water deprivation test. And so as the nurse, your responsibility for preparing these patients that have suspected diabetes insipidus for a water deprivation test, you're going to be expected to take a few baseline measurements. So you'll take a baseline weight, you'll take a baseline urine osmolality or send that off, and a baseline serum osmolality. We deprive then these patients of fluids for about 8 hours. During that span of the 8 hours, we're taking serial measurements of the patient's weight and urine osmolality. If at the end of that 8 hours, that urine osmolality remains pretty much unchanged, we're then going to administer a drug. It's called desmopressin. And what desmopressin is it's basically synthetic antidiuretic hormone. So we're giving these patients antidiuretic hormone. If then, after administration of that antidiuretic hormone, urine osmolality goes up, that tells us, hey, this patient definitely has an issue with antidiuretic hormone, so that confirms a diagnosis of diabetes insipidus, okay? So we give them the ADH, urine osmolality goes up, like, oh, okay, now they have the ability to concentrate their urine after we give them synthetic ADH. That confirms a diagnosis of diabetes insipidus. Okay, so we've got the diagnosis. Now, what are we going to do about it? Well, the biggest, scariest thing with diabetes insipidus is going to be hypovolemic shock. And so what we're going to do is to treat that. So we've got to administer IV fluids, maybe vasopressors to maintain a good blood pressure. And then we're going to give the patients desmopressin, all right? So over here with SIADH, it's always about what is the scariest, worst potential complication. So with SIADH, we have pulmonary edema and we have seizures. With diabetes insipidus, we have hypovolemic shock, all right? So we're going to treat those things accordingly. Over here, we're doing fluid restrictions. We're giving diuretics to get fluid off. Over here, we're giving them fluid and we're giving them desmopressin or synthetic ADH to help them hold on to fluid, all right? A couple of teaching points if your patient happens to be sent home on desmopressin. Since we're giving these patients synthetic antidiuretic hormone, they're going to have a propensity now to hang on to water. So the provider may advise the patient to restrict fluid. We're also going to need to inform the patient of signs and symptoms of hyponatremia, okay? So headache, nausea, confusion. You need to inform the patient or educate the patient on those potential signs and symptoms of hyponatremia if they're sent home on desmopressin, all right? So that pretty well wraps up the etiology, a very quick patho, the priority assessments, the priority interventions, the most scary potential complications of SIADH and diabetes insipidus. I hope you guys have found this video helpful. Please visit NursingSchool911.net for more helpful videos and other resources. And I just hope you guys are having a great semester, and thanks so much for watching my video today.